Okay, we have Dr. Josh Benditt back up, and I'm assuming that his consumer rating, based on the fact that he practices at UW Medical Center, is very good.
High, super high. Yeah. Great, Dr. Kalmus, thank you for a lovely talk. I learned quite a bit. I was a little worried that we were going to overlap a lot. There's a little bit, but not that much, because I'm going to focus on the respiratory kind of issues following the operation. But what I would say, most definitely in complete agreement, that the successful post-op course starts long before surgery, and I would completely agree that there are really, other than trauma, there are no urgent surgeries where you cannot do some research beforehand. Now, I did looking around for the issue of post-polio syndrome and surgery, and there really is very little. The one disease where there is some data, and I think this is an interesting article that I helped put together, but in the American College of Chest Physicians, we did a position paper, a statement on managing patients with Duchenne muscular dystrophy who are undergoing anesthesia or sedation in 2007. There are, as far as I can tell, really few to no other statements about the management, operative management and anesthesia for patients with neuromuscular disease. And really, although no two diseases are identical, there are a lot of physiologic issues that occur similarly in the disease processes. So I'm going to use this as a guide, and I think it is applicable in terms of respiratory issues during and following operations. Now, we've already gone through some of the effects of surgery on the lung. The points that I'd like to kind of underscore is that secretion clearance is really impaired after general anesthesia and surgery, and that is why particularly we pay attention to secretion management in the post-op period, and I'll show you what we do. The effects of the problems with secretion lead to a lot of things. Hypoxemia is the first one, so low oxygen levels, atelectasis and collapse of the lung, but this can lead to pneumonia and respiratory failure in the post-operative period, and that is certainly something that you do not want. And one of the last questions about they couldn't get me off the ventilator following surgery is related to the fact that you can develop frank respiratory failure, the inability to breathe on your own after surgery and general anesthesia. Okay, so again, slight overlap here, but the pre-op evaluation, you know, there's the surgical process and where are you getting operated on, what position you'll be in, and so forth. But anesthetic agents, and particularly for some of the muscular dystrophy, there are certain agents that should not be used. I would say overall, for anyone with any kind of respiratory impairment going into surgery, the most minimally invasive approach is appropriate because in general, that means less likelihood of general anesthesia, intubation, etc. Post-operative care is critical, and I'm going to review for you that, in fact, one way of getting people off of the mechanical ventilator with intubation is to actually put them on non-invasive ventilation as a bridge to breathing on their own. They will certainly need cough assistance, and the site of care, not only the hospital in particular, but where within the hospital are you? For many of our patients, especially with more advanced respiratory failure, we will have them come to the ICU after the procedure rather than being extubated immediately and tried to be placed on the floor where there's less monitoring available. All right, so I would suggest certainly seeing a pulmonologist to guide workup. I would say that I would strongly suggest getting preoperative pulmonary function testing, which would include the things that we've already talked about today: a vital capacity, the maximum inspiratory pressure, cough flow, and CO2 analysis, either end-tidal or arterial blood gas. And I think that should be done close to the operation, because in many of the disease processes that we're talking about, they're progressive. And if you had it last year, it may not be the same as it is currently. Okay. The anesthesiologist should certainly see you preoperatively, and I would suggest that this be a separate visit with the anesthesiologist, and they would review a lot of the things that you've heard about. But in addition, and particularly in post-polio, where there can be issues with the spine, head positioning, and so forth, is the intubation difficult? Now, most anesthesiologists obviously can intubate even in very difficult situations, but it will help them prepare if they know if you have any spine problems or have had previous difficult intubations. Is it possible to do under local anesthesia? And I would strongly suggest that if at all possible, it be done under local, because as you've already heard, putting an endotracheal tube into the airway has lots of issues that go along with it. The type of anesthetic, intravenous anesthetic, may be better for some types of diseases, such as Duchenne muscular dystrophy, and we actually recommended that they use intravenous sedation as the main type of anesthesia for those patients. Okay. So the operation itself, the least invasive procedure possible, as I've always said, and also the shortest procedure. I think length of time, certainly under general anesthesia, but even under local anesthesia, makes things more difficult. There will be less coughing and secretion clearance during that time period, which just makes more likely other complications. Now, if intubation is required, there are ways of doing it without actually putting a tube all the way into the trachea. There's something called laryngeal mask airway, which actually goes sort of above the vocal cords and is a little less invasive, and sometimes that can be done. Although in some cases, patients are extubated when they're not fully awake. For the patient with neuromuscular disease, they really should be fully awake prior to being extubated. I think that's important because respiratory drive is decreased when you are sleepy. Certainly, in the operating room and immediately post-op, the anesthesiologist should be immediately available. They usually are, and I would certainly say at academic institutions, they will be there with you the full all the time. Okay. What about this IV medication and anesthesia? For many of our procedures where pain is a little bit less, so for instance during surgical or radiologic gastrostomy tube patients with a placement, which some of our patients need, we can get away with just intravenous medications such as propofol and fentanyl for getting them in a state that allows the tube placement with a little bit of local anesthetic on the abdominal wall. I'm going to show you shortly that we've used non-invasive ventilation in concert with this intravenous medication for sedation. And in fact, as part of the muscular dystrophy guideline, we suggested that if your forced vital capacity is less than 50% predicted, you probably want to have non-invasive ventilation available. If it's less than 30, we suggested that just about everybody get that, so that during the procedure they're actually being ventilated with a mask. And certainly if you have carbon dioxide retention at baseline, we suggested using non-invasive ventilation with conscious sedation. All right. Performing a procedure while on non-invasive ventilation, it is very possible. It's well documented in the literature. We published a paper for Duchenne patients, but many others, including both ALS, Duchenne's, other muscular dystrophies. It avoids the complications of intubation and general anesthesia. There's a respiratory therapist who is present during the procedure to monitor effective ventilation while this is being given. The monitoring overall, so pulse oximetry, EKG, et cetera, is similar to while you're under general anesthesia. Okay, this is a picture of a patient of ours. This is an ALS patient, but who got a PEG tube, so a percutaneous gastrostomy tube placed under endoscopic guidance while receiving non-invasive ventilation via face mask with a little bit of conscious sedation. And we've now done, gosh, I don't know, probably 40 or 50 of those, I would guess, over time. And this is documented in the medical literature that it's quite doable. Okay. All right, what about post-op care? The sites for post-operative care for our patients really are the post-anesthesia care unit. Many of the patients that I have pretty advanced respiratory failure, are on daytime ventilation as well as nighttime. And so after they come out of the PACU, where they usually stay for several hours, almost all of them go to the ICU for monitoring for at least a day or so after the procedure. Depends on how big a procedure it is. Sometimes it's longer than that, but almost always a day. Now, if you have near normal breathing function and you're not on any kind of home ventilation, you may not need to do that at all, but I would suggest, certainly for the patients I see and for many people who are using home ventilation, it's probably safest to be in the ICU. At my hospital, the pulmonary critical care division takes care of all the ICU patients. So my colleagues are working in the ICU and I talk with them whenever I have a patient coming in for surgery, which helps with that communication issue, which I agree is a really big deal, because if you go and you come in and the doctor who's in the ICU doesn't know anything about post-polio syndrome or muscular dystrophy and what a bi-level device is, that's a problem. So communication between your physician and the team is important. So in the post-op setting, I think it's wise to do continuous EKG monitoring, certainly in the post-anesthesia care unit and the ICU, blood pressure, oximetry, and then some form of carbon dioxide monitoring, which I've already mentioned is pretty crucial. A lot of times in the hospital, this will be arterial blood gases, but end-tidal CO2 is a possibility. Okay. Now, big question, and it was already raised about what about getting off the ventilator and ventilation in the post-operative period? Non-invasive ventilation post-op may be necessary. Unfortunately, there is extraordinarily little data available, and our statement, as I've already suggested, said that based on the preoperative pulmonary function, we should probably be helping these people here with breathing after the operation. Almost all hospitals nowadays will have a bi-level type device that can be used in the ICU. They're usually used with a full face mask, but if you've brought your home mask in, at least where I work, you can use that. I definitely suggest that people bring in their own equipment. Now, this is a kind of hot topic among hospitals because there's liability if you bring in your own equipment and you're using it and something happens. But at least currently at our hospital, you can use your own home bi-level device. We often have some of our more severe patients bring in their cough assist devices, although we have them available in the hospital. But I would suggest bringing it in, and you can find out if your hospital allows you to do that. So, some kind of breathing support will be needed in these people, maybe in others if there's CO2 retention. The minimum is until they're fully awake and able to breathe on their own. Now, as I said in my first lecture, using oxygen alone can be a problem. And however, if you're using a bilevel device, you can have oxygen bled into that. So even if you developed atelectasis or VQ, ventilation perfusion, inequality or mismatch, and hypoxemia, if you're on the non-invasive ventilator, you can bleed in oxygen to correct that. But I think oxygen alone, although it's not always the wrong decision, you should have data on what their carbon dioxide level is before you start oxygen alone. All right. Now, as I kind of already mentioned, effective cough post-operatively is absolutely crucial, especially for bigger operations, for reasons that you've heard. The cilia are not working. During the operation, you're not coughing. There's some collapse of the lung and great difficulty getting secretions up and out of the lung. Now, I would agree completely that the incentive spirometer is critical, but if you don't have adequate muscle strength to get you up to the full volume, it may not be all that you need. And so for patients who, again, have that low peak cough flow, and even for others, we suggest having the availability of the cough assist device in the ICU. If you have one, bring it in. You may want to speak with a respiratory therapist at the facility prior to the procedure, or at least have your pulmonologist do that. At our place, and again, most places that deal with neuromuscular patients, they will actually have those available in the hospital, know how to use them, but they may not. And, as I'm going to mention at the end, the family may be the one who's most knowledgeable in using the device and may actually be able to help the respiratory therapist to learn about the machine. Okay. Hyperinflation maneuvers, like using that resuscitator bag that I described earlier, might be helpful but are not likely not sufficient because they don't actually get secretions out of the airways. Okay, I already went over this, assisted coughing. This will certainly in any abdominal surgery not be possible, but both abdominal and thoracic surgeries, I would say you don't want to use that. But, if you had something done to your foot, that would be totally reasonable to do. The cough assist is critical. I remember when I first suggested that we bring this into the hospital, everybody was laughing, what the heck is that? Oh my God, it's a vacuum cleaner. Just go out and get a vacuum cleaner. And now it's like being used on everybody. I mean, intubated patients who have no neuromuscular disease, they're just using it on everybody. So this should be available for people who have cough weakness following an operation. Okay, pain control. I think this is absolutely critical. There were a couple of questions on this already, but although it is known that pain medication can suppress breathing, adequate pain control should not be sacrificed for the sake of breathing. That is, some people try to tough it out and say, oh, just don't give me any morphine or fentanyl or anything at all like that because I have neuromuscular weakness. And that should not be the case because actually pain will interfere with secretion clearance quite dramatically. So you should have that controlled, and the pain service in the hospital should be monitoring you daily, nurses monitoring you probably, hour by hour, and the pain should be controlled because you need to cough, and in order to cough, you cannot be having abdominal pain or chest wall pain, things like that. Okay, family involvement. This is also a little bit of a hot topic, but we actually encourage this, and for our neuromuscular patients, oftentimes the family members are the one who knows the most about the patient's management. And we have them come in, and so especially for our younger patients, we'll have moms, dads, people who can use the equipment come into the ICU and help out. And I am the head of the respiratory care department, and I've made it very clear to all our respiratory therapists that they should look at this as a positive, not a negative. Sometimes there can be, especially in the ICU, a little kind of political infighting on things like that. But really, the family knows best in these cases. As I said, bring your own equipment in, even if it ends up not being used. I think it's good to have it there. And then if the facility is not familiar, I said training should occur before surgery, but maybe it should just be going to a bigger center. That may be the best way to go. One that has familiarity with the types of devices that I'm talking about. But for instance, up in Washington, which is a little bit less densely populated than you guys are down here, even an hour or 2 hours from Seattle, there are lots of places where they don't have experience with it. And what we do is we talk with them on the phone, and the patient's family will educate the therapist. And we've had pretty good success in doing that. Okay. So I'm going to summarize, and hopefully I've finished a little bit early to get us back on time. And we'll do some questions. But I think that the post-operative success depends on all three of these things, all right? So pre-assessment by a pulmonary doctor, seeing the anesthesiologist as well as the surgeon, critical. The operation is also important, the least invasive surgery possible, and if it's a surgery that's amenable, which certainly some of the extremity surgeries, gastrostomy tubes, things like that, will be amenable to conscious sedation and non-invasive ventilatory support. The post-op care, need to monitor the oxygen and the CO2, can transition to non-invasive ventilatory support as a method of getting somebody extubated, and a little bit longer stay in the monitored setting to make sure that things are moving ahead in a reasonable way. So I will stop there and take any questions.
Thank you.
Sure.
Is a thyroid surgery a big surgery or small surgery as we picked it?
A minor surgery?
No, thyroid surgery, like a thyrectomy.
Oh, thyroid surgery. Yeah, that's a little bit bigger surgery.
So you haven't heard of local anesthesia for that?
I'm not an expert in that area. I have not heard of local anesthesia for like a thyroid resection. Maybe for a biopsy of...
for removing nodules and...
my experience, usually if they're going to remove the thyroid, they'll do it kind of anatomically, so they won't do just single little areas. That's a kind of a bigger surgery, and I would suggest that probably would require general anesthesia. I don't know, I would guess.
It's interesting. I'll just make a quick comment. It is possible to do thyroid surgeries, depending on exactly what's done, with local anesthesia. And we're moving more and more to local anesthesia. The barrier has been the surgeons, but they're developing the ability to operate that way. There might not be quite as good surgical results because it's not quite as perfect. You're swallowing as the surgeon's pressing on your windpipe and so on, but it would technically be possible. And this is an area where you might want to check with another surgeon and see, are they familiar with that? But in the past it was done. That was the anesthesia for thyroid surgery, was local. So.
Thank you.
It's not always possible to have a pre-op with an anesthesiologist. What I've run into is a resistance. You cannot meet with them, and they're resistant to even looking at your literature. In my surgeries, I have copied post-polio literature and always an article by Dr. Selma Kalmas, and you just about have to chase them down to give it to them.
Yeah, that's really interesting. Yeah, I'll let Dr. Kalmas talk about that.
The night before, they're usually assigned to your case.
Right.
And
Right.
in one instance, I had an anesthesiologist call me at 10 o'clock at night. The person that had been assigned my case quit when he found out I was a polio because he knew nothing about it. And luckily, I got someone that did, because her mother was a polio, so she had learned something about it, and I was quite comfortable with her.
Yeah, this is kind of frightening to hear, which is another reason, by the way, to aim for a major academic medical center. Most of them will have pre-op clinics, and you would be scheduled for a visit at the clinic sometime before your surgery. You would be seen by typically a trained nurse practitioner who has an anesthesiologist available for consultation. And the nurse evaluates you based on criteria. And if there's anything out of the norm, for example, a post-polio patient would normally require at least a call to the anesthesiologist who was covering the clinic that day. And then they could come and see you and so on. All the information is recorded on a form, and then this is moved through the surgical process. So if there's a change in who's assigned to you on the day of surgery, the information, the evaluation of you is there for that person to have. And I know it's hard for you to understand why you can't see an anesthesiologist beforehand, but the operating room is a dynamic organism that changes and fluxes, and people get sick and emergencies come in, operations take longer than we expect. It's just really very difficult to schedule a request for that particular anesthesiologist that day. And again, an academic center is going to give you the best transmission of information, and people who want to know, who would seek out the answers to polio and not the kind of problem that you got. I know I'm kind of disparaging the community hospital, but you deserve the best care, and so go where you get the best care. I made the comment to the other man about getting another surgeon, and I know that sounds, I want to say, kind of uppity, but you deserve what's best, and you have to go find it many times. And so take that responsibility and understand that sometimes you have to do those things.
Hi, Dr. Benditt, or the director of the respiratory
Sure.
department. As a respiratory therapist, I wanted to say, when you bring your home equipment, sometimes biomedical won't let us use it if you haven't got it maintained and proof of that. So we'd like to use your own equipment, but we can't if you don't have proof of maintenance.
Right, sure.
And the cough assist device that's handled by the family members, they do know a lot more about what works best for the patient, especially synchronizing it. We have an auto mode or a manual mode. And I don't know if you have protocols, but sometimes they use them at pressures that I don't think we'd be comfortable with. Really high pressures.
Too high, or?
Well, not too high. It's what works for the patient. But just intuitively using that equipment, like putting an inspiratory pressure of 40 and a negative of 50 would be kind of scary as an RT, thinking you might collapse their lung. But that's what the family does with this patient at home. So,
Well, those are kind of typical pressures that we use. You know, it isn't, it's interesting, it never, I don't think we've had any barotrauma. It's reported in the literature, but sometimes you need very high pressures for certain patients. And so we just use whatever, pressure.
So you don't have a protocol limiting your RTs from doing that? You advise them to start with high pressures?
Yeah. Or, if they were concerned about it, to start with lower pressures and move up. But if the patient comes in with, plus 40 over minus 50 or minus 60, yeah, we keep it right where it is. And,
Well, we're often in the position where we're initiating it, and it's the suffocator.
Sure.
They're afraid of it.
well,
So we're not starting really high.
Sure, no, I think it's okay to start lower and then kind of move up as needed and just see what's effective. But we often find for adults, it's just you require much higher pressures. I think because even though it's pressure at the mouth, what happens in the lower airways, because of resistance issues, is much lower pressure.
I've been told that it brings the mucus halfway up, unless you use enough pressure to.
You mean what they, there's always the sort of worry about occluding the trachea with a big mucus plug. We have not had that issue, and if you just do it repeatedly, generally.
So we can go on and on as high as we want?
Yep.
All righty.
We have them, well, no, it's interesting, at home, the cough assist, we might have somebody on plus 40, minus 50, and they might use it every 5 minutes while they have a cold, and they might use, 6, 8, 10 repetitions of the exhalations. So, yeah, they use it a lot. Yeah.
Yes, thank you. This was partly answered the question before last. But for a routine thing like a colonoscopy, I'm 66, the last quite a few years the doctors keep saying you need a colonoscopy routine. But I'm scared to death to go under for just a local test that I don't have any symptoms for. I mean, what do y'all recommend to your patients and so on?
Well, that's a really good question. If it were something that were really needed, that's something that could be done with non-invasive ventilatory support, no problem. But, now there's virtual colonoscopy, and it's a little debated as to the accuracy of that test, but I think for somebody with significant respiratory involvement with a neuromuscular disease, I would recommend something like that, probably. But if you absolutely needed it, bi-level support during it, totally fine.
Question.
This probably doesn't apply to the kind of surgeries you've been talking about, but what I've seen with the HMO that I'm connected with is that there's what I think a disturbing practice of sending people home, same-day surgeries. They're really not out of that anesthetic when they discharge them. They have to have somebody drive them home. They cannot possibly go home in a taxi. And they often go home to no care at all.
Yeah.
And I'm just stating that, my discomfort with that kind of thing, and I'm sure it happens to a lot of people.
Yeah, no, I would suggest for that nobody with any significant post-polio syndrome and respiratory impairment or any other kind of neuromuscular disease with impairment of, breathing, go home the same day. I think that would not be right, and I would have probably the pulmonologist write a note saying that you need more than that. Because I agree, they try to push you out. I mean, even non-HMOs. So definitely longer, even though the hospital is a dangerous place, longer is better for the monitoring and assurance that you're doing well. Yeah, definitely.
Okay. The last few people who have been talking, Dr. Combs and this respiratory therapist over here, it's very interesting. She was saying about, well, you need to get your cough assist machine, the maintenance records for it to make sure it's well maintained. Well, first of all, if I could find a respiratory therapist who knew what the workings were of a cough assist machine that supplied me with it, that would be interesting. And I think that's just one step that's kind of crazy, because who takes their cough assist machine into the respiratory place anyhow, unless there's a problem with the operation of it, in which she didn't know herself. The other thing I want to tell is, Dr. Collum, is I was scheduled for a neck surgery at C2, C3 at the UCLA Orthopedic Hospital, and my doctor, who I will not name, wanted me to stay in 2 days for it, and they ran out of Micardis, a blood pressure pill, and the young whippersnapper orthopedic surgeon who was on duty couldn't find a replacement in their pharmacy, and it was 1 o'clock in the morning. My pressure's going up. He doesn't want to give me a substitute for it because nobody's there to give it. And I tell him, well, look, I'm going to take my own. And he said, you do that, you're going to be discharged. I asked him for some water, took it, got discharged. Number 4, rated by Business Week. I'm beginning to wonder if there is any institution, any doctor, okay, that will treat post-polio syndrome and do it correctly.
Well, the question is a little bit strange, because high blood pressure is not post-polio. That's another cause, most likely. The hospitals aren't perfect. The accreditation processes aren't perfect either. I want to give you an avenue if anything like this happens again. You are free to call the Joint Commission. They have an 800 number. You can make a complaint, and they will very often send someone out to the hospital, or they will call the hospital administrator or whatever. The state's Department of Public Health also has a way for you to lodge complaints. It's actually on their website. And feel free to complain, because that's what it takes to get these very complicated institutions, all going in the same direction. I want to just say orthopedic surgeons are orthopedic surgeons. They're guys that like drills and saws, and they don't know too much about meds. And so there might have been a way to link up with a medicine person. There should have been a medicine resident on call who could have facilitated what was needed, or found another drug. So make your complaints, because those will make the system better. And if you don't complain, it's going to stay the same. And people are working very hard to try to get better, and at least we're measuring things like complaints, and that's a big step.
Okay, one final question.
Earlier you said something that having a colonoscopy, you could use Propofol, right?
Could use what?
Propofol isn't what they use for colonoscopy?
Propofol.
Yes.
Oh, yes, yeah. Not necessarily propofol, but they might use like a benzodiazepine, like Ativan or Versed.
So which
But
one
they
is
might
safe?
use propofol.
Which one is safe?
Oh, well, all of those drugs are okay. There's no problem with that. It's just both of them are what we call conscious sedation, which is okay, and I think it's better than general anesthesia, but it would require, if you have breathing issues or using a home ventilator, that you get that during that, because when you get sedated, the hypoventilation tends to occur, so the carbon dioxide goes up. So, but any of those drugs would be fine. I don't think there's a problem with that.
I'm leaving my rest of my questions here.
Okay.